Instead of doing our normal podcast news type situation, we thought what we do today is upload and play for you guys the audio from our ABC hearing today. This ABC hearing was in regards to us staying open in November at our physical location in Lexington, Kentucky, and the health department shutting us down and the ABC revoking our license. For those who are unaware, in January of this year, we got our license back until pending the results of a hearing. The hearing today was the first evidentiary hearing of this case. You'll hear the state put on a COVID expert, to the individuals who were there the day that the health department pulled our license from the health department, as well as a person from the ABC. On our side, you'll hear myself testify about what happened that day, and you'll also hear an expert we put on. The cross-examinations, every time I hear the state put on a COVID expert that we hear and we see, is always very shocking to me, as I think that they are very underprepared and not very knowledgeable, and it raises a lot of concerns of who is deciding this policy. I appreciate you guys listening and always supporting us as we continue with not just our fights, that is to say what the government can or can't do with the business, but include in our movement of pushing back against government tyranny completely. We always appreciate your support. And one way you can show support is to donate. You can go to donate.broodco.com, or you can also purchase our coffee, our merchandise at shop.broodco.com, BREWEDCO.com. We appreciate you guys showing us that support, and please share this out with your friends, your family members. Hopefully you take a good listen to it. There's a lot of interesting moments in this testimony across all sides that I think everybody in this country should hear.
In most of the cases, like I said, we have had asymptomatic transmission. So in those individuals, somewhere in that 2 to 14 days, they begin shedding the virus without any symptoms. So you wouldn't be able to tell if they were symptomatic or not. And so typically, I think the average has been 7 to 10 days if people are contagious. But we do know that they've been contagious because of asymptomatic spreading. It's generally about 24 hours before those first symptoms show up, if they're going to get symptoms.
So you had said flu symptoms start 1 to 4 days after exposure, and COVID symptoms start 2 to 14 days after exposure. How does it spread? How does COVID-19 spread?
So COVID-19 is spread through airborne droplet transmission. So right now, as I'm talking in this room, I'm spraying airborne droplets. Those of you that aren't even speaking right now, just inhaling and exhaling normally, you are spraying airborne droplets. You can spread airborne droplets through singing, talking, coughing, sneezing, pretty much everything you're doing where air is coming in and out of your body. And so COVID-19 is spread through those droplets to others that are nearby.
Okay. And you said nearby. Can you explain that a bit further?
So in the public health world, we look at typically for airborne droplet spread diseases, you're looking at a 3 feet barrier. So it's your arm's length typically is what we look at. That's typically around 3 feet. For viruses such as this, where it's new and we are trying our best to protect as many people as possible, barrier gets extended to 6 feet, just to make sure that if I were to cough or to sneeze, that those particles couldn't float further than that 3 foot window. And so what I like, if you've ever pictured one of those games where people have a bubble suit on and you're banging into each other, that's what we were looking at. So you're looking at a 6 foot radius around a person that we were trying to use to keep those airborne particles from spreading person to person.
So these are, I'm sorry, can you tell if someone is contagious with COVID-19?
No, unfortunately, you can't just look at someone and know that they have COVID-19.
And why is that?
Well, for one, like I said, we have asymptomatic transmission. So, I'm feeling perfectly fine and still spreading the virus to others. Secondly, we have allergies in Kentucky, and a lot of the symptoms of COVID-19 mimic allergies. So, I don't know how many times in the correctional facility outbreaks I worked or long-term care where I thought it was allergies. I came into work anyway. I thought it was allergies, and it turned out to be COVID-19. The illnesses range from asymptomatic, mild, to very severe, and we've seen, people all along that continuum. So it'd be very difficult to walk into an and say,
I'm sorry, the doorbell of letting somebody in the room bleeped you out a little bit.
Oh, sorry.
You said the difficult to walk into, and that's it.
Okay. It's difficult to walk into an establishment and look around and say, this person has COVID, that person doesn't have COVID.
And you've given a great deal of information now about COVID-19. On what are you basing this on?
So a lot of the information that I've talked about is from CDC, from the Centers for Disease Control and Prevention. Also, our articles from the New England Journal of Medicine and from the National Institutes of Health.
Okay. Are those established medical journals, or what are those?
Yes, the New England Journal of Medicine and is a widely accepted and used journal publication, and the National Institutes of Health is an organization similar to CDC.
And in reading those, why did you read those journals?
Well, as an epidemiologist, it's our job to know if we're going to go out and do mitigation and investigation and talk to groups about strategies to prevent the spread of illness. It's our job to research and to understand the topic that we're looking at. And so during this entire pandemic, all of us epidemiologists spent a great deal of time researching the latest information on COVID-19 so that we could give the best guidance and assistance to the organizations we were serving.
Yeah, thank you. I don't know that we've discussed this yet, but I do want to return to it if we have. How long after infection are you contagious? As a person contagious? Right.
So typically, if I were to have COVID-19, today would be day 1, and typically I'm going to spread that virus for around 10 days. We do know that in some individuals that are immune compromised or that have very severe illness, that they can spread up to 20 days. But for typically most people, it's going to be 10 days that you're spreading the virus. We also understand that you may be able to test somebody on day 20 and still find viral particles on a swab, but those particles are not infectious. It really looks like the infectivity of the virus goes down dramatically after day 10.
And how can you tell whether something's infectious or not?
So if you're asking, are you asking about how, the scientists have determined that at CDC?
No, I'm asking essentially if COVID-19 is present in the particles, how can you tell whether those are infectious or not?
So there's been a lot of research that has been done by different groups of scientists, like at CDC and other states, where they've looked at, on those swabs, whether, they swab someone at day 20, and if that, they can use that to then reinfect lab rats and in laboratory settings. So CDC has put out several research articles that have determined that 10-day window.
Understood. And when you testify here about COVID-19, you said you've come about this knowledge through research into medical journals. Are there any other methods that you use to determine this information?
Besides that, just working with the team we have here, we have CDC experts at the DPH team and other laboratorians and epidemiologists and scientists here that We do, information sharing. Some of the mitigation strategies, not necessarily the science, but the mitigation strategies, those are learned over years of practice of being an epidemiologist and how those mitigation strategies work.
Okay. And we'll get into the mitigation strategies here very soon. The journals that you mentioned, are those peer-reviewed journals?
Yes.
Okay. So let's see. Let's move further. So having, I guess, established sort of a basis of knowledge on COVID-19, you said that the response to COVID-19 began before March, but what measures have been undertaken in Kentucky to combat the spread of COVID-19?
So going back all the way to 2003 when I started as an epidemiologist, Kentucky had to develop pandemic influenza plans and other disease outbreak support plans. And so in those plans, when we looked at how we would combat a novel virus, whether it was a novel influenza virus or a novel other type of virus, we looked at different strategies that we would use to combat that, because we have no treatments, we have no vaccines, so how can we keep this from spreading? And so the biggest thing that we looked at is what we term non-pharmaceutical interventions. And so in that part of the plan, we talk about strategies such as face mask usage, hand washing, hand hygiene, surface cleaning, social distancing, those types of messages that we could put out to the community, because combating a virus where you have no known treatments and no known vaccines, we're trying to do the best we can to keep that from spreading in communities. And so those plans have been in place for decades. And so when this virus first popped up in China, we began to pull those plans out and look at, what of these strategies that are in all of these plans could we use to combat COVID until we could get treatments, until we could get vaccines.
And those non-pharmaceutical interventions you speak about, have they been used in prior novel virus outbreaks?
Yes. So in 2019, we had H1N1, which was a novel influenza virus. And so we used a lot of the same non-pharmaceutical interventions during that pandemic. Fortunately, we were able, because it was a flu virus, to develop a vaccine very quickly and deploy that very quickly. And so we didn't have to use the full cadre of non-pharmaceutical interventions like we did for COVID.
And what do you mean by the full cadre of non-pharmaceutical interventions?
So in 2009, we didn't do face masking, and we didn't really do any of the capacity restrictions that we deployed for COVID. We did do messages on hand hygiene, on surface cleaning, and on social distancing.
And if you could just remind me, what were the non-pharmaceutical interventions that were undertaken in this particular pandemic response?
Right. So we pushed social distancing, and for social distancing, we used 6 feet. We also did capacity limits to aid in the ability for establishments to do social distancing. We did messages on hand hygiene, on surface cleaning, and the use of face coverings.
And so you spoke about sort of social distancing. What's the purpose of social distancing?
So to get back to what I said just a minute ago with the bubble, if you're talking about a 6-foot bubble around each individual, that means if we're staying 6 feet apart, if I were to cough or sneeze or even just talk, my airborne droplet particles would have a really hard time getting to the person next to me. In all likelihood, they're probably going to go 3 or 4 feet and fall to the ground. And if there's no one between me and you in that 6-foot window, they're just going to fall to the ground and be gone. So the thought was that if we could keep people apart, far enough apart, it would be very difficult for those airborne particles to go person to person.
Gotcha. And so what you mentioned face coverings. How do face coverings help combat COVID-19?
Right. So For face coverings, the point of face coverings for the general public is, and even in medical settings, is to keep your germs to yourself. So if I have something over my mouth, it's going to be very difficult for my airborne particles to get through that cloth and go into the air. There is some minimal protection to the person wearing it from the airborne particles around them. But unless you're wearing a fit-tested N95 respirator, you're not getting a lot of benefit from not picking up other people's germs. It's mostly to keep your germs to yourself and keep them from entering the airspace.
So the purpose of wearing a face covering is not personal safety, but sort of public safety.
Correct. It's to keep the people around you from coming in contact with your germs.
Okay. And you mentioned hand hygiene. How does hand hygiene help combat COVID-19? So
hand hygiene is the number one public health measure that we use for all diseases to stop the spread. Early on in the pandemic, we weren't 100% sure how this disease was spreading. And so we did a lot of recommendations for surface cleaning and hand hygiene because we weren't sure if contaminated surfaces were leading to some of the transmission if it wasn't just solely airborne. But as we've moved forward, we've been able to do better research and understand that there's very limited spread on surfaces and on hands. It's mostly airborne transmission. And so, but hand hygiene is always a good thing to promote, and it's something we always try to promote in all settings in public health. Do
bars and restaurants play a distinct role in the spread of COVID-19?
So, we deployed all of these non-pharmaceutical interventions to long-term care facilities, to correctional facilities, to church schools, to any setting where people congregated. But restaurants and bars posed a particular challenge because the activity you're going to that place to do is going to cause you to spend a large amount of time without your mask on. You can't go to a restaurant and eat and drink masked. And so we realized that those places were particularly problematic because of that. In a long-term care facility setting, for instance, we can make all of the residents stay in their rooms. We can make everyone in the facility mask and keep those people safe. But in a restaurant, because of what you're there to do, you're going to have to remove that mask. And so we knew that would potentially create a public health hazard just by the nature of what you're there to do.
And
something we always try to promote.
As far as bars specifically, as opposed to restaurants, are there any specific implications of the bars on the effects of, on the spread of COVID-19?
So, bars are also offer up a unique situation. Typically, in a restaurant area or just a standalone bar, the space is smaller. People will be unmasked potentially for longer periods of time, closer together. And what you're there to do at a bar generally is to consume alcohol. And we know that alcohol inhibits your thought process, just the nature of what it is. And so in a setting like that, you have people who would be participating in an activity that would be inhibiting their thought process and their thought for their safety. And so you could be creating additional safety hazards the more people consume beverages around a bar setting.
And so with that in mind, are there any measures specific to bars and restaurants that have been undertaken? So
we looked at doing social distancing and capacity limits and masking were kind of the areas we looked at with bars and restaurants. So the social distancing allowed for the capacity limits allowed for social distancing to happen easier. If you're looking at an establishment that can hold 100 people, if you cut that down to 25%, then those 25 people can space out better in the facility. You can get that 6 foot of distance. So that was why there were capacity limits. And we did this for dining in long-term care facilities and corrections. It wasn't any place that we knew that people could congregate to consume food and beverages. We tried to limit capacity, and we tried to socially distance those spaces.
Is limiting capacity related solely to assisting in social distancing? Are there any other, what other implications come from, or what other benefits may come, if any?
Yeah, it was mainly just to make it so that social distancing was easier to accomplish.
Okay.
We felt like if we set those capacities, it would make it easier for the restaurants to understand how many people they could fit in a space and still maintain that 6 foot of distance.
Is as far as indoor spaces, are there any greater concerns or lesser concerns between indoor and outdoor spaces?
Right. So I'm not an industrial hygienist. I'm an epidemiologist, so I can't speak to air ventilation, air exchanges. I don't have any expertise on that. But what I do know is that in an indoor space where people are unmasked, you're going to have airborne droplets that are in the airspace that is there. And so the more people that are unmasked, it stands to reason the more air droplets that are being put into the airspace that people are located in. And, CDC has put out a lot of research on outdoor activities. And we know, too, just from, my background in biology, if you're trying to do virology in a lab conditions are perfect. And when you start to add UV light and air flow and temperature changes, those viruses break down really quickly. And so we know that being outdoors, there's a lot of different things that can cause the virus to degrade very quickly out there as opposed to an indoor space.
So I think are there any other measures that have been undertaken to combat COVID-19?
Yeah, those were the main ones. As everyone on this call is aware, since around mid-December, we had a vaccine and we were able to deploy that vaccine. So that's completely changed the game since December as far as efforts that we can do to combat the virus. But up until mid-December, these were the only interventions that we did to try to stop the spread.
Okay. So when one of these safety measures is put into place, how long does it take to show effects on the incidence, if any?
Right. So one thing that's important to note is that there's really no way to break apart and look at did social distancing versus masking make a bigger difference. Because of the severity of this illness, we deployed them all at the same time. And so when we look at them, we're looking at them all together, not as individual interventions. And so typically what we look at is, because of that 2-week incubation period, you want to look at interventions needing to last at least 2 weeks in order to change, because you need all of those people that were exposed the 2 weeks prior to those measures taking place to either become ill or not and finish their quarantine, and then you would see changes in the numbers of people that were being infected.
Have we seen any measurable effects from these interventions?
Yes. And so, when we were sitting back in September, we were seeing cases rise dramatically, in some cases doubling each week. And so we were very concerned at this upward trajectory of the cases. And so, we did see a dip after these interventions were done in November. And then as soon as they sort of lifted and people went back about their business of holiday gatherings and eating and drinking and being with people outside of their family bubbles, we saw a dramatic increase again in cases. But then we've seen a dramatic drop off since then because of vaccine.
And there's, I have a chart that I'd like to show you.
Yes.
Okay. And you provided that you provided me with this. What can you explain this chart to me?
So this is an incident rate chart, and so what incident rate is in epidemiology is the number of cases over 100,000 of population. So it's a way that we can even out the numbers and be able to compare, for instance, counties to counties. And so this is for the entire state, and you can see there around September the 1st, we start to see this marked increase in cases. And then you'll notice a little dip right there, right after, and then it pops back up. That little dip is actually from the Thanksgiving holiday. We just didn't have a lot of people that got tested and a lot of people that got results. And so that's why it dips and then pops up. But then you can see that second orange pop there, that is where those interventions were taking place. And so that dramatic decline after that is attributed to the interventions that were going on. And then the spike after that is approximately 2 weeks after those orders were lifted and people went to holiday gatherings and went to bars and restaurants and other establishments after that. And then, like I mentioned, that dramatic decline after that is when vaccine became readily available in Kentucky. And so our numbers have dropped very dramatically since then.
Okay, so sorry, let me go back a little bit. So the Executive Order 2020-968 was issued on November 18th, and that's the one that shut down indoor dining. At that time, how many people were known to have been infected in Kentucky?
So around 145,000 people had been infected from March until that point in time in Kentucky.
Okay. And do you know how many of those people had died from COVID-19?
Approximately 1,700.
Okay. Do you know how many people, and I'm sorry, it appears that around that time, is it safe to say that the number of cases were increasing?
Yes.
Okay. And what concerns did that create?
Our main concern really from the beginning was hospital capacity. We were very concerned at this point in time with what this was doing to the hospital capacity in Kentucky. And so it's important to understand when we talk about hospital capacity, COVID was happening on top of all of the regular stuff that happens in hospitals. And so we were seeing hospitals that were running out of ICU space, that were potentially cutting it close on having enough ventilators. And so really the ramifications of that is that if there's a 10-car pileup on I-75 today, and all of the ICU beds are taken in the Lexington metro area, what happens to those people? And the medical providers would have to make tough decisions on, who's going to get these limited resources. And especially if they're already all taken with COVID patients, then what? So from the beginning, we were trying to protect the citizens of the Commonwealth, but we were also trying to keep our hospitals from having issues where they had to potentially ration care or make really tough decisions like they did in other states.
And you provide another chart on that, if you could. I'd like to provide that. Can you explain this chart?
So the blue line that you were looking at, and this is Region 5, so this is the Lexington metro area. This is not the entire state of Kentucky. And for those of you that are familiar, even the Lexington metro area has several large hospital systems that would be in that region. So the blue line is inpatient admissions, and these are just COVID cases. So you can see that we were seeing this uptick in those cases as well in October. We were also seeing spikes in ICU usage. ICU and inpatient go together a lot of times because COVID patients will come in as inpatient, they decline, they go to ICU, they improve, they go back to the regular floor, all the while remaining an inpatient. And then you can also see that ventilator usage, it was having some spikes there in October, but we started to see some even bigger spikes in December, after the orders were lifted. And ventilator goes along with ICU. So a lot of times people, when they decline and go to the ICU, they decline further and are on a ventilator. And a lot of our patients, spent 6, 8, 10 weeks on ventilators. And so that's why that line stays kind of flat, is because a lot of times they're on that ventilator for a very long period of time.
Is it a guarantee that if you get infected with COVID-19 that you will be inpatient?
No. We've had a lot of patients, especially in my work with long-term care facilities, we had a lot of patients that were asymptomatic and were very mildly ill. But we did have, some care facilities where they sent out half of their patients to the hospital for care. COVID is one of those illnesses, like I said, it ranges from asymptomatic to very severe illness and death. And so it's very unpredictable what will happen. I mean, just looking at the cases in our master line list, we have individuals that are 99, got it, maybe had a sniffle, they were fine, and we had individuals that were in their 40s that died. So it's very, very difficult to kind of answer that question about, how someone will, their outcome, what someone's outcome will be.
Sorry, I'm very close to a very loud street, so sometimes I need to mute to make sure that I'm not drowning out and deafening everyone with the noises that pass by my house. This blue line does not necessarily, if you're not necessarily going to be inpatient, this line does not necessarily represent the entirety of the I guess the incidence of COVID-19 in Lexington or Region 5.
Right, but you can see that those match as far as the upswing in cases, and you can see.
I'm sorry, you cut out again. Those match.
It matches the incidence curve that we were looking at earlier. This uptick, those upswings match very closely, and you can see, in the hospitalization chart, there was a spike there right around the time that the order was put into place. A really large spike of inpatient cases in Lexington, and so when you're looking at the reason that graph humps and bumps there is because those individuals that were exposed right as the order was put in place were becoming ill in those following 2 weeks and being hospitalized.
Right. So, looking at the capacity chart, is there any other explanation for this decrease or this decline that this chart shows?
Right. So I've explained the first little bump down and bump up there. And we saw, it was Thanksgiving, no one went to get tested until the next week. And so it created an artificial little bump there. But the decline after that matches up with, the 2 weeks after those orders were put into effect. We just were not seeing as many cases as we had been seeing previously. And if you look, the next big spike is the after Christmas spike. So after the orders were lifted, about 2 weeks, that's the spike that we got because everyone went back out to resume their holiday celebrations.
Gotcha. So I'd like to move to admit these two charts as complainants exhibit or departments exhibit 1.
Mr. Reese, any objection?
You're muted.
Muted.
Sorry, there we go. Subject to my same objection about the expertise in all of this testimony in general. I do make that objection. And I don't think she said that she prepared this data.
That was not covered. I will agree with that.
I did say that she provided it to me. I can ask her whether she prepared it. Ms. Bolden, did you prepare these charts?
I did not prepare the charts.
Who did prepare these charts?
Our main data epidemiologist, Ben Scott.
Okay.
This goes to the expert issue also. I mean, every bit of her testimony has largely been hearsay. If she's an expert, she gets to, rely on hearsay. If she's not, all of her testimony has to be stricken. So I have the same standing objection to this that I've had all morning.
I will fold it in with a consideration that's been previously held under submission, but if it's admitted, I will mark all the charts that's been used so far as Exhibit 1 from the department.
Thank you. So if restaurants and bars had continued to operate normally instead of this order going into place with COVID-19 no COVID-19 restrictions, how do you believe Kentucky would have been impacted?
I'm going to rate. I know I've had a standing objection. I'm going to make a specific objection to this particular question. It calls for speculation. It calls for. She's not testified that she's done any studies about the effectiveness herself of these interventions. We are in rank speculation here that I don't even think an expert, because there's been no testimony about methodology or anything else that would give rise to being substance for this. There are all kinds of problems with this, even under a 703 expert in terms of reliability and everything else. So I make the objection now on this question and its answer.
Well,
I'm going to, Mr. Newton, do you have a response to that?
I want to ask a different question, but related.
I did this specific objection occurred roughly at 9:59, so I will make sure to distinguish that. But I believe it kind of goes into the original objection, Mr. Wiest. But I'll let Mr. Newton move forward since he's.
So just for the record, yes, ma'am. Just for the record, my original objection was to her qualifications and capacity to testify. We're now into her testifying about things that really go to Daubert, and there is no way that this is reliable under a Daubert standard, what he's calling for. So I'm raising the objection. It's simply rank speculation.
I think this will need to be covered then in a more formal written format, which you're free to do in the post-hearing. But either way, for time-wise in the record, I know that about 10 o'clock, this is when the objection was made. So, Mr. Newton.
Thank you, Ms. Stevens. In states, in surrounding states that did not put these in place, did you find similar dips?
Yes.
Around these times?
And that data is widely available on CDC's website. And if you go to other states' websites, CDC actually produces a chart every day on their website that shows the incident rates in other states. And so you can look at states where these interventions were not done and see that their cases continue to climb while Kentucky's dropped and kind of flattened off a little bit.
Let's see. So if a restaurant or bar were to have ignored the mask mandate for the patrons, do you believe that would have created a hazardous condition for the patrons?
Yes. I believe that if we're going back to November, we were seeing such dramatic spread across the Commonwealth that establishments that were allowing patrons to gather closer than 6 feet, ignoring mask mandates, ignoring capacity limits, were creating hazardous environments for their patrons and for their staff. As I spoke before, we know that masks offer minimal to no protection from the air around people to the people that are breathing it in. And so, they were creating hazardous environments for staff that were in that environment for 8+ hours.
Okay. And I think you covered my next question, which was ignoring indoor capacity restrictions. You said, I believe, that you believed that that would create a hazardous condition if they ignored them. If a restaurant or bar had ignored the temporary prohibition on indoor dining from November 20th to December 13th, 2020, do you believe they would have created a hazardous condition for their patrons or employees?
Same
Yes.
objection.
You say yes?
Yes.
Okay. Can you think of any legitimate reasons why a restaurant or bar would ignore these measures?
Objection.
It'll be the same treatment for these objections, but you can move forward, Mr. Newton.
Thank you.
Yeah, Your Honor, I just want to be clear. Now we're speculating about what bar owners may have been thinking or what their justifications were. I mean, we're way outside epidemiology now. She's a mind reader, and I mean, this is absolutely impermissible testimony.
The law states that if a hazardous or physically offensive condition is created with no legitimate purpose, then it is a disorderly premises. That is not going to the intent of the party involved, but rather a more factual designation of what a legitimate reason is.
You've got an epidemiologist testifying about what the reason a bar owner could have or not have for something.
I will sustain that part of the. I mean, just if we could limit it to Ms. Boland's knowledge and what she would normally prepare or encounter in the course of her duties, then I think we'll be on the right track.
Okay.
You may proceed, Mr. Newton.
Thank you. And do you believe that a restaurant or bar that ignored these measures created a threat to public health, safety, or welfare?
I do.
And why is that?
Like I've stated previously, we were seeing cases increase dramatically. And so from an epidemiology standpoint, we know that the disease was spreading rapidly person to person through not only Fayette County, but all of the counties in Kentucky. And so with the incidence rate being that high at that time, having establishments that were allowing people to gather without masks, without social distancing, was creating a definite public health hazard.
Well, thank you. I have no further questions.
I have extensive cross-examination.
Well, let me just check in. We're about an hour in. Ms. Boland, do you need any kind of water break or anything like that?
Can I have 5, please?
Yeah, that would be fine. I usually take breaks about an hour or so. So if we could just come back at 10:10, it's now 10:05. We'll resume the cross-examination with Mr. Wheat.
Stand by. I'm on the record. The time is 10:14 a.m. I can't hear.
Are you ready? I'm sorry. I was waiting to tell me you were ready. Sorry.
Yes.
Good morning, Ms. Boland. My name is Chris Wiest. I represent Dean's Diner, LLC, doing business as Brood in this matter. Let me start with just a couple background questions. Do you believe that the governor of Kentucky took effective measures to prevent the spread of COVID-19?
Yes.
Do you believe that at any time the governor failed to take necessary action to protect the public? And was there something he should have done that he didn't?
I object to this. It's not relevant.
Counselor, for the last 45 minutes, we've heard testimony about people being endangered by not following the governor's orders. And I think I'm allowed to test the efficacy of the orders as well as that contention. We're right in the heart of cross-examination.
I'm going to allow the question, although I think it could be reframed better as far as Ms. Boland's knowledge and what she's encountered in the course of her duties.
Sure. Ms. Boland, to your experiences, the governor failed to enact any public health measure that you think he should have done to protect the public from COVID-19?
No.
Okay. Let me ask, do you have a master's in public health?
I have a master's in public administration, community health.
Okay. So the answer to that question, do you have a master's in public health, is no, correct?
Yeah. Correct.
True, you also do not have a medical doctorate degree, correct?
Correct.
It would be true that you're not licensed to practice medicine in the Commonwealth.
Correct.
it's true that you're not an industrial hygienist, correct?
Correct.
And obviously that would mean that you're also not a certified industrial hygienist, correct?
Correct.
And I think part of your testimony on direct was that you recognized that industrial hygiene was the science and art devoted to the anticipation, recognition, evaluation, and control of environmental factors such as including diseases, right?
I guess.
Okay. You personally have not conducted or participated or researched, well, let me back up. You personally have not conducted or participated in any studies on COVID-19, correct?
Correct.
You personally have not conducted any peer-reviewed research on COVID-19 yourself, correct?
Correct.
You yourself have not published in the area of COVID-19, right? You've not published or engaged in any publications?
I have a publication that's being submitted in the long-term care facility research. It's being submitted to a journal, but it's still in review.
It's still in review. It's not been peer-reviewed at present, correct?
Correct.
Okay. You personally treated any COVID-19 patients?
No, because I'm not a medical professional.
Have you personally observed the treatment of any COVID-19 patients?
No.
You use the term we saw patients throughout your direct. Would it be fair to say that that was simply something that was reported to the Department of Public Health from people that were engaged in frontline treatment?
Yes.
In terms of your testimony here today, would it be fair to say that really all of it was based on hearsay, information that other people were passing on to you in your capacity of as a public health department employee?
No.
Okay. What did you personally observe in terms of COVID-19?
I personally worked with and talked to several long-term care facilities, correctional facilities, those serving those places where individuals were having outbreaks of COVID-19. I talked directly to those administrators and nursing leads.
Or did you personally go into those facilities?
No.
Okay. So again, that was just information that those facilities were passing on to you, right?
Yes.
Your testimony on direct was that you believe that COVID-19 was spread primarily, I think actually you said it was through droplets that were being emitted when people talk or sing, etc. Is that fair?
Correct.
Are you aware that recent studies have suggested that it's actually aerosols and not droplets?
Yes, but we were talking about our knowledge in November.
Okay. So you understand the science behind public health measures relies in part on understanding how the disease spreads, correct?
Correct.
And if in fact we now know that it was aerosols rather than droplets, the public health measures that would be appropriate for aerosols versus droplets would be different, correct?
Correct.
So as we sit here today, let's talk about a couple things. The 6 foot, you talked about needing social distancing and the 6 foot barrier as being one of the public health responses throughout this pandemic, correct?
Correct.
If in fact it's aerosols that are driving the COVID-19 spread, those stay in the air, right?
Yes.
And obviously social distancing may not be enough to protect against those, right?
Correct.
Let me ask, as an epidemiologist, are you aware of any certified industrial hygienists that have rendered opinions that in fact the appropriate and better course to keep people safe would have been ventilation and appropriate HVAC equipment to destroy the virus?
I'm not aware of those articles.
Okay. And you yourself, I think we just talked about, you're not a CIH, so you can't speak to those issues. Fair?
Fair.
If an individual restaurant had adequate ventilation and an HVAC system that was destroying the virus, there would not be a risk from that facility, would there?
I'm not an industrial hygienist, so I don't know.
You don't know. Okay. Do you have any evidence as you sit here today that the respondent comply with any 6-foot distancing requirements?
I was not involved in any of the investigation at that facility, so I'm just here to talk about the epidemiology of the disease.
Okay. You mentioned that you reviewed CDC materials and New England Journal articles in rendering your opinions here today. Fair?
Correct.
What specific CDC materials did you review?
So I looked at MMWR articles, which is the mortality journal articles that they put out, the Morbidity and Mortality Weekly articles. I also reviewed other articles. When you would look at the MMWRs, they give other peer-reviewed journal articles that they cite in those articles. So I reviewed some
articles.
I'm sorry, I would have to go and the list.
As you sit here today, you can't cite to me any specific article. Fair?
No.
Okay. You indicated the New England Journal articles you reviewed as the basis of certain of your opinions today as well. Fair?
Correct.
Which specific New England Journal articles were you relying on?
There was one that was specific to looking at transmission of COVID-19 in facilities.
And what was the title and author of that study?
I don't have that available.
You can't cite that for me either. Okay. You talked about prior experience as partially driving the public health response. When, in your experience, have we ever previously shut down indoor dining throughout the state?
Not in my experience have we shut it down through the state. I've been personally responsible for shutting it down in different investigations I've been a part of.
And that's in the event, for instance, that there's a bad salmonella outbreak, you got to shut down a restaurant to eliminate the source. Fair?
It's usually when the public health, there's a risk to the public's health by practices that are occurring inside of the establishment.
And in that sense, then it's an establishment where you're seeing the disease specifically come out of the establishment in question, right?
It's where the practices that are being done in the facility are creating a public health hazard where disease is spreading from what the facility is doing.
Are you aware of recent OSHA guidance that have suggested that mask mandates are not effective because we're dealing with aerosols and not droplets when it comes to COVID-19?
I'm not aware of those.
Have you read the National Academy of Science Press February 23rd, 2021 article that revealed the COVID particles were aerosols, not droplets?
No, because we were looking at November.
I understand what the outcome was, but the testimony and the suggestion is this facility presented a public health risk. And if the science has revealed, subsequent science has revealed that that's not quite the case because we're dealing with aerosols, not droplets, it's relevant to whether or not this facility was a hazard. So the answer was, though, that you did not read that February 21 study. Fair? You indicated that you believe that the governor's interventions helped stop the spread of COVID-19, correct?
Correct.
And your testimony was also that other states that did not have those interventions did not have a drop-in case. Fair?
Can you rephrase that?
Yeah, I think your testimony was that states that did not have these public health interventions did not have a case drop into December, right?
Correct.
One of the states that I think is rather notorious for not having any mandates was South Dakota. Would you agree?
I've read that.
So your understanding is that South Dakota did not have any kind of public health mandates such as Kentucky, right?
Yes.
Are you aware that South Dakota's highest case rate was 1,855 new cases on November 14th, 2021?
I've not studied South Dakota's case history.
Okay. The testimony was that you looked at states that didn't have mandates So you saying that you didn't consider South Dakota as one of those states?
What I said was that there is a chart on CDC's website that shows cases. And so when you look at Kentucky compared to other states, our increases were not as dramatic as other states on the chart.
So you were looking at, was this an aggregation of every state on that chart?
Every state is listed. Their curve, their epidemic curve is listed on that chart.
So you would have had to have observed South Dakota's, right?
I was only looking at Kentucky and the states above it. I was not looking for specific states, no.
Okay. Would it surprise you to know that South Dakota, notwithstanding not having mandates, actually had a substantial case drop, and by November 29th, 2020, was down to 801 cases?
I don't know anything about what was going on in South Dakota and what they were doing.
What states were you comparing Kentucky to then?
On that chart, you would have to look at the chart to see what states were above there. I don't have it in front of me right now.
So as you sit here today, you can't identify any particular state in which did not have mandates and had a case increase.
I don't know what states had what mandates at what time. So looking at the chart, even if I had it available to me, I could not tell you if that state had a mandate or not.
Well, without knowing that, you could not evaluate whether or not the mandates were effective, correct?
No. You can evaluate based on looking at the incidence rates of the cases. So just looking at the lines, the curves of the lines, and what happened to our case numbers.
You would have to compare the states that had mandates and the states that did not have mandates to figure out whether or not the mandates had any correlation with public health outcomes, correct?
You could look at it that way.
You would have to look at it that way to evaluate whether or not the mandates were effective, correct?
I was only looking at Kentucky's data. And so looking at Kentucky's data, we can know when the mandates were issued and then look to see what happened to the case incident rates after those mandates were issued.
Well, if every other state, including the ones that did not have mandates, had a similar curve, we could probably determine that the mandates had no outcome in terms of disease progression, correct?
No.
Are you familiar with the 1918 pandemic flu?
Yes.
You would agree with me that in that instance, there was likewise, and by the way, there were not a lot of public health interventions in that pandemic, correct?
To my knowledge, there were mask mandates that were issued. There were other guidance that was issued by public health.
Guidance, okay. And are you familiar with that disease progression following a similar curve?
I would have to look at it. I will be honest, it's been several years since I've researched the 1918 pandemic.
Okay. As you sit here today, you don't know one way or the other.
Correct.
You indicated that the public health department had a pandemic response to H1N1. Fair?
Yes.
Was masking required across the state?
No.
Was 6-foot distancing required across the state?
It was recommended but not required.
Okay. Did we shut down restaurants throughout the state?
No.
I want to go back to Fayette County in November of 2020. I believe that you indicated that the case count or the incidence rate, I think when we looked at the chart, it was right around 70 per 100,000. Fair?
Yes, there was 14,000 cases at that point.
And so if just on average, if there were 100 people in a bar or restaurant like Brood, that would correlate to approximately 0.07 people with COVID. Fair?
No, you're looking at 100,000 per population, so you can't extrapolate back that way.
Okay, so if Fayette County, I mean, we can. So Fayette County's population, I think, is 300.
Correct.
Okay, that's roughly 3.2, right?
Sure.
So that's, I think that would be about 210 people that had COVID throughout the entire Fayette County at the period in question, right?
That would be 220 people that had tested positive for COVID. There's no way to know, because not everyone's getting tested, how many people actually had COVID in the community at that point.
Okay. So it's an unknown. Fair?
Correct.
But in terms of what we knew, we know about 210 people tested positive, right?
Correct.
So if there were 100 people in Brood, in a population, just the percentages, that's still a 0.07 people for those 100, right?
Of people that we knew had tested positive. You're looking at two different things there. You're looking at incidence rates, and then you're trying to extrapolate numbers, and that's not, because we know there's so many people that would have the disease that were not getting tested. You're only looking at numbers of people that were positive. So it's not an accurate way to depict that data.
There was significant concern about ICU and hospital beds at the beginning of the pandemic, correct?
Correct.
So much so that we set up field hospitals, including at Kroger Field in Fayette County, correct? Familiar with that?
Yeah. I was trying to remember, sorry.
To your knowledge, was a single one of those beds ever used?
Not to my knowledge.
Was it ever the case that the ICU usage in Fayette County got full?
I'm not the expert on the hospital preparedness program, but looking at the chart that we had up, we were approaching capacity of the state that at capacity.
Okay. You're familiar, I don't know, are you familiar that the Kentucky Hospital Association has put out data about bed usage throughout the pandemic?
Yes.
Are you familiar with what the data was on that in November of 2020?
No.
Okay. Without looking at the data, we really could not assess whether or not the ICU data or the ICU usage was at or near capacity, could we?
Can you rephrase that?
Yeah, without looking at the Kentucky Hospital Association data, we cannot accurately look at the hospital bed usage or even the ICU usage, right?
Right, but we were looking at that data.
Okay. Would it surprise you if I told you that it looked like hospital bed usage was around 60% in November of 2020 from the KHA data?
That's roughly what it looked like on the graph.
Okay, and the ICU usage was right around that same number?
Are you talking about just Lexington or for the state as a whole?
Well, I was looking at really the region in question. I think it was Region 5.
Region 5?
Yeah. The KHA data showed that, again, ICU usage was only at about 60%.
That's roughly what was reflected on the graph.
Okay. Let me ask, the governor lifted the restaurant mandate in mid-December of 2020, right?
Correct.
And yet case rates were increasing, right?
They began to increase around, if you look at the chart, around 2 weeks after that was lifted.
Right, and the governor did not put in another ban on all indoor dining after that point, did he?
No.
And your testimony was that nothing the governor did endangered Kentuckians, right?
Correct.
Okay. All right. Let me ask, I've got some studies. I just wanted to see if you had read them or not, peer reviewed. Have you read I think it was received, revised, accepted, it looks like it was peer reviewed 21 July 2020, the paper on a country level analysis measuring the impact of government actions, country preparedness, and socioeconomic factors on COVID-19 mortality and related health outcomes?
What journal is that from?
Yeah, it is from, it's an Elsevier submission, and it looks like Science Direct. It was in eClinical Medicine.
I'm not familiar with that journal.
Okay. So that study indicated that mandates such as those enacted by the governor of Kentucky had no correlation with COVID-19. You're not familiar with that journal, right?
I'm not familiar with that journal.
You read the research paper, Effect of School Closures on Mortality from Coronavirus Disease 2019, Old and New. by Ken Rice et al.
What journal is that from?
School of Physics and Astronomy. Was it published by the University of Edinburgh?
I would not be looking at journals of physics. Okay.
How about the Frontiers in Public Health? It was an article. It looks like it was November 19, 2020 publication. COVID-19 mortality, a matter of vulnerability among nations facing limited margins of adaptation. Have you read that study?
Again, what journal is that from?
Yeah, that's in Frontiers in Public Health.
I'm not familiar with that journal at all.
Okay. You have the Centers for Disease Control and Prevention, MMWR, recommendations and reports from...
I'm sorry. Could you slow down when you read that? Thank you. I'm still trying to write it.
Have you read the Centers for Disease Control and Prevention, MMWR? This is a CDC publication dated April 21st, 2017.
What's the... Which article in that? Because there's several that would be in that.
Yeah, so this is volume 66, number 1. It's recommendations and reports, and the title of it is Community Mitigation Guidelines to Prevent Pandemic Influenza, and it's 2017 publication.
I probably read that when it came out in 2017, but have not revisited that since.
Are you aware that even in that, it does not recommend full business shutdowns?
Like I said, it's probably been 6 years since I've read that.
I think your testimony was, in terms of this particular establishment, you're not familiar with their HVAC system and you have no personal knowledge about the particular risk that this particular bar may have had. Fair?
Fair.
I have nothing further from a cross-examination standpoint.
All right, thank you, Mr. Newton. Do you have any redirect?
Yes. Misty. So I want to return to your education. Can you restate what your education is?
I have a bachelor's degree in science and biology and public health and a master's degree in public administration community health. Sorry,
I'm getting some noise outside, so I had to mute my microphone. And in your background as an epidemiologist, can you explain sort of the what sort of epidemiological principles that you apply when you work through these meters?
Well, it's important, I think, to note that in order to be an epidemiologist 3 at the Kentucky Department for Public Health, you have to take at least epidemiology classes and at least 2 statistics classes. So there's a minimum qualification for that. So just because the degree is not public health does not mean that that those qualifications are not there. As far as to answer your question about my epidemiology experience, I've presented at several national conferences about different epidemiology investigations. I've been published in at least one journal and in a local publication. I've also presented at several state conferences and received several certificates over the course of my 15 years as an epidemiologist. And so, when you first start as an epidemiologist, you learn the principles of epidemiology, which is, we try to discover the cause of the outbreak and then mitigate the spread of the outbreak and to stop and slow the spread of the outbreak. So, taking those principles that you learn in school and then applying them over the last 18 years, there's a lot of, just like with any occupation, a lot of what you're doing is based on your experience in the field and those different outbreaks that you've investigated.
And so when you were confronted with the COVID-19 pandemic, what principles did you base your response to your recommendations on?
Right. So, in public health, we try to do the best that we can to protect the most people from becoming ill. And so we really looked at what measures were available to us in the face of not having a vaccine, not knowing when a vaccine could or would be available to the community, not having any treatments for this disease. What could we do to keep people safe and to keep the least number of people from dying as possible? And so when we worked with all of the different groups that we've had to work with, that was what we were looking at. What can we do to protect the most people possible in the face of something that we had no cure for and no treatment for?
And so how does having no cure and no treatment translate into the measures that were taken?
We, as I just stated, we were really trying to do the best we could to keep people safe and to keep people from becoming exposed to the disease. Because we know that Kentucky has very poor disparities in health. We're number one in the nation for asthma and diabetes. And so we knew that we had a very vulnerable population just day to day. And so we really were trying to do the best we could to keep the disease from spreading like wildfire through the community.
So you mentioned that you had to take into account the specifics of the population of Kentucky in your response. Is that a common practice in epidemiology?
Yes.
So how does that work typically, if comparing to other states?
So epidemiologists, we look at the population as a whole. We're not medical providers. We don't look at individual patients. We look at the population as a whole. And so all of the states have data on their populations that show, how healthy or unhealthy their populations are. And knowing what we knew about COVID and what we know further now, we knew that a lot of our population was going to be very vulnerable because of that. And that's just a part of epidemiology. Just like when we looked at other outbreaks I've worked, like the hepatitis A outbreak, we knew that was affecting the population of people who had been incarcerated and people who were injection drug users. And so we did initiatives to try to protect those people and that group of people.
Are there other factors that are weighed in other than the vulnerability of the population to specific illness or being immunocompromised from territory to territory?
Yeah, I think in this one, because it was a new virus, it was novel. We knew that no one had any immunity to it. We were really looking at the entire population as a whole. And so, yes, there were pockets that were going to be more susceptible to COVID, such as people with diabetes, people with obesity, people with asthma. But because everyone was equally susceptible because it's a new virus, we felt like we had to do these extreme measures in order to protect the most amount of people. I think that we really worked hard to try to do that, to protect the most amount of people we could.
And as are there any other variables that affect the incidence in your knowledge and sort of transmissibility of outbreaks in a territory, other than the health of the population?
Right. I think in this instance, the biggest factor was that this was a novel virus that no one had immunity to. And looking when we first started in COVID, they were saying it could be 2 years before we had a vaccine. We had no treatments for it. So we really felt like we needed to do what we could to protect everyone from the spread.
There were calls to have different sorts of responses and measures county to county. Is there a reason why that would be, or why those weren't adopted? So
Kentucky is a home rule state, and that means that the counties can have some ability to to create their own regulations, their own rules, their own policies, whether that's through the local health department or the local and city county governments. And so, as a state, we tried to issue regulations that, went across the state, but local jurisdictions, could also issue regulations if they felt like it was necessary.
Mr. Weiss brought up South Dakota. Are you aware of any conditions in South Dakota that differ from Kentucky? Outside, are you aware of any conditions within South Dakota that would affect incidents as opposed to Kentucky?
I have not extensively studied South Carolina's population.
Are you aware of any that
South Dakota, sorry.
Are you aware of any sorts of concerns that could, from state to state, change?
Yeah, I mean, all states are different. All states have different populations. Population density, how closely people are crammed in, that varies from state to state. So states that are more in the Midwest, like North Dakota, South Dakota, obviously have less population density than in Kentucky.
How would population
even though they may have the same population number. So population density is just the number of people in a community, how densely those people are packed into that community. So, oftentimes in more rural areas, like even looking at Kentucky, far eastern and far western Kentucky, the population density is not what it is in Louisville or Lexington.
And how does population density affect the spread of the disease?
So the more densely packed a population is, the more chances you have for disease to spread. The more chances you have with interactions between individuals in the community.
So if there was a population that was more or less populous or population dense, would that change, or how would that change, if at all, the response?
I don't know how it would change the response, because we were looking at just doing regulation across the state or mandates across the state. But, looking from an epidemiology side of it, we do know that there's a lot of literature out there that supports, when you're looking at disease spread, it's much more prevalent to have disease spread in denser populations than in not as dense populations.
And as far as H1N1, you said that you worked a bit on the response to H1N1, and that in that instance we didn't use the sort of extreme or severe sort of restrictions that were present here. Why is that?
So there were a couple of different reasons. The first one being that we did have an effective treatment for that in some pharmaceuticals. I'm trying to think of the non-brand name, but Tamiflu. We knew that Tamiflu worked against it. And so there was a treatment available that was seeming to be effective. We also know that it was not causing the mortality that COVID has been causing. And so, there was a little bit less concern about mass mortality from that. And we were able to get a vaccine out because it was a flu virus, and we have the capability to make flu vaccines very quickly. We were able to get a vaccine out for that. I think the first cases were in the United States in April, and we were vaccinating individuals in September. So it was a very, very quick turnaround, much, much quicker than COVID.
And so what sort of interventions were adopted for H1N1?
So for H1N1, some of them were the same. So in long-term care facilities, we asked them to not do visitation. We asked them to not do communal activities. Same thing with correctional facilities. We worked with the schools to do hand washing, cough covering campaign. I think when those first cases showed up in April, I don't think Kentucky got the first cases based on anyone until sometime in May. And so, schools were going out. So schools came back in. We really pushed those hand hygiene messages and covering your cough. But at that point, we were almost ready to roll out a vaccine to those individuals.
Understood. Mr. Weiss brought up that the research is showing that it's aerosols and not droplets. Can you explain the difference there?
So droplets are heavier and fatter. They fall down out of your mouth to the ground a lot quicker than aerosols, which can linger in the air. Okay.
And with aerosols, is social distancing ineffective against the spread?
It's not as effective. Social distancing is always an effective way to prevent the transmission of diseases, but it's not as effective against aerosols as against droplets.
And is masking ineffective against aerosols?
No. Like I said, the point of masking is to keep your germs to yourself. So because they're smaller, they may, if your mask is not on correctly or it's not double layered like it's supposed to be, you could have some additional aerosol droplets, or not droplets, aerosols that are able to escape it. But for the most part, it is still the most effective strategy of keeping your droplets and aerosols to yourself.
Social distancing and masking?
Yes.
With that in mind, there was talk about the use of proper ventilation or ventilation systems that may destroy. I know you said that you aren't an industrial hygienist, but does the evidence show that, does the evidence show that the measures taken, despite there being potentially other methods, were effective at all?
Yes.
Wouldn't the research find that it was more in aerosols and not in droplets?
The most recent literature on that has been coming out, early this year, February, March. Like with any disease, the further we go along with it, the more we learn. Science is an ever-evolving process, and so the more we go forward, the more we're learning about how this disease is transmitted and what it potentially can do to those that are infected with it.
So, what effect does that changing knowledge have on measures that are adopted?
I think that it as we move forward, we've adopted and we've changed things as needed to match the science and to match what's going on in the area. So, I think the biggest thing that's made the biggest change is the vaccine coming out. The reason that things can be lifted and we can start to return a little bit to normal is the vaccine, and not in November. In November, it did not look like it was going to be available. For at least a couple of months, and we were able to roll that out in December. I think you're muted.
If I could, I'd like to introduce Ms. Boland's CV as an exhibit.
Yeah, I object. It was not disclosed in evidence.
I'm going to let you submit it, but then I will package this with the other consideration related to the determination of whether or not she will be labeled as an expert witness.
Okay.
Just for the record, this is violating the pretrial order in this case. So I just wanted to make that clear for the record.
I think it fits under the C as far as like when it was submitted as documents or other evidence necessary for impeachment or rebuttal. But this is definitely a part of the consideration that's been discussed since the beginning of this hearing as far as Ms. Boland's credentials and how they will be viewed with the testimony. So I will allow the entry of it in for that consideration, knowing that it's going to be determined as a whole as to whether she'll be labeled as an expert.
And I have nothing further. I can provide that to Mr. Wiest and to the hearing officer as well.
That would be fine. I mean, I'm sure Mr. Wiest may have written objections that will accompany that. But if you could get that to both of us, that'd be appreciated. Or redirect for Ms. Boland.
You broke up a little bit.
Mr. Newton, are you still cross-examining Ms. Boland? Or
no, I have no further questions. I'm sorry.
Okay, sorry. Mr. Wiest, do you have any recross?
I do. Ma'am, your testimony was that you published one journal. What journal did you you published in one journal? What did you publish and when?
I'm pulling my CV. I was published in the American Public Health Association in their annual conference literature.
What year?
2006.
And what was that publication on?
Competency-based education for preparedness staff. And I was also published in Kentucky's Epidemiological News and Notes and Reports.
What year?
October 2005.
On what?
Investigation of an outbreak of skin rashes in Carter County schools.
You've not been published on COVID-19?
Correct.
Some additional public health outcomes, and let's talk about some of those because I think you talked about public health outcomes. Would you agree that unemployment is leads to adverse public health consequences?
I don't. That's not something that I've studied.
How about increased cases of depression? Has that led to adverse health outcomes, public health outcomes?
I'm not a behavioral health expert.
Increased rates of suicide, has that led to any adverse public health outcomes?
Again, I'm not a behavioral health expert or epidemiologist.
You know whether or not we've seen increases in all of those things as a consequence of the public health interventions that we talked about here this morning?
I'm not in the behavioral health part of the cabinet.
Part of your testimony was that H1N1's vaccine was available far quicker than the COVID vaccine, correct?
Correct.
Okay. And you said that H1N1 came out in April of 19 and the vaccine began in September of 19, correct?
No, it was 2009.
2009, okay. So April
Correct.
2009 to September 2009 was the H1N1 vaccine?
Correct.
Okay, that's 9 months, correct?
No.
So April, May, June, July, August, September.
6.
5 months, okay.
Yeah.
6 months, okay. And COVID, I think we first saw that in March of 2020, in Kentucky anyways, right?
In Kentucky.
And the vaccine, I think you indicated, was available in December of 2020?
Mid-December of 2020.
Okay. So that's about 10 months?
Correct.
You indicated that there's been no effective treatment for COVID. Fair?
I said that when we were looking at deploying these, that were not effective treatments identified.
Okay. addition to the vaccine, are you aware of multi-drug treatment that's been employed for COVID?
Yes.
Okay. Has that been effective?
In some individuals, but not overall, and not for all cases.
Okay. Are you familiar with a study entitled Multifaceted, Highly Targeted Sequential Multi-Drug Treatment of Early Ambulatory High-Risk SARS-CoV-2 Infection? It was published in Cardiovascular Medicine, December 30th, 2020.
I'm not a physician, so I would not have read a study like that.
Are you aware that masks do not meet key OSHA respiratory protection standards?
I'm not an industrial hygienist, so I don't know about OSHA.
Okay. Right. And I think you've testified you're not familiar with the National Academy of Sciences Press, the February 23rd, 2021 study, correct?
Correct.
And so you're not able to comment on the findings in that study that masks, because of aerosols, are ineffective, correct?
Correct.
Okay. And I think that concludes my recross.
All right. I'll see if Mr. Newton has anything further, Mr. Newton.
Nothing further.
All right. Do you anticipate having to recall Ms. Bolin?
No, I do not.
Okay. Ms. Bolin, unless maybe somebody specifically calls you back, you are excused for right now. Thank you so much for being here. I appreciate your presence. Thank you.
Thank you.
Thank you.
You are excused. All right, it's 11:04. What is the next witness you intend to call, Mr. Newton?
Okay. I'm back on the record. The time is 11:11 a.m.
All right, Ms. Sanders, I'm going to ask you to raise your right hand. If you could hit on me, thank you. You swear or affirm the testimony you're about to give is the whole truth and nothing but the truth?
Yes.
Ms. Foster, it's your witness.
Hello, can you state your name for the record, please?
Karen Sanders.
And how are you employed?
I work for the Lexington-Fayette County Health Department.
How many years of experience do you have in that?
I have multiple years of experience starting since 2007 working in Maricopa County, Arizona.
Do you have any certifications?
Yes, I'm a registered environmental health specialist, registered sanitarian through the National Environmental Health Association, and I just received reciprocity for a registered sanitarian with the state of Kentucky.
What does your job entail?
Routine inspections for restaurants, swimming pools, public accommodations, doing complaint inspections, doing opening inspections, conducting foodborne illness inspections.
What led you to visit Brood on November 24th, 2020?
They were due for a routine inspection.
And how did that inspection come to be assigned to you?
During our team meeting, we go through and assign 1, 2, 3, 4 for the inspectors, and that was one of the restaurants that I was assigned.
So it's just a random assignment?
Yes.
Had you received any complaints prior to that time about Brood?
No.
What did you observe on that day?
I arrived, and when I went up to the door to look at their score sheet or their scorecard, they had a sign that said that they were open and that they had a garage door, which made them be considered a patio. I went into their facility and to go to the front counter to speak to the employee there, and I noticed that there were customers inside the facility at that time.
Was that surprising to you?
Yes, as that was one of the first few days of the closure for in-person dining.
Okay. What happened when you spoke to staff?
I let at the time I didn't know it was Mr. Cooperrider. I just went up and let them know that I was with the health department. I was there for a routine inspection, and I let them know that they needed to be closed to in-person dining.
What was their response?
He said that he had a garage door and therefore could be open, as he considered it as a open patio.
What did you do in response?
I let him know that what was considered outdoor dining would be having more than 50% or more of your outside walls open to the air.
I'm going to share my screen here so that I can show a document to the witness. Can you see this document, Ms. Sanders?
Yes.
Does this look familiar to you?
Yes, that's my handwriting.
Can you explain to us what this document is?
It's a notice to correct, and it's something that we give to facilities if we see something that is against one of the codes. And as you can see there, it was for the Executive Order 2020-586, the Kentucky Healthy at Work requirements. And that was something that we give to them whenever we observe those violations.
Okay. Did you provide a copy of this notice to Mr. Cooperrider?
I believe at the end of our time there, Skip Castleman provided copies because he took the copies that I had.
Did you ask him to sign this?
I did at one point, yes.
And what was his response?
He said he didn't want to sign something that he didn't agree with, so he was not going to sign it.
Okay. Your Honor, I move to introduce this. I'm not sure where we are in the exhibit numbering.
Yes, potentially it's exhibit 3, but Mr. Wiest?
I object on the basis that all of this was ultimately rescinded by the health department because we got into a dispute with them over the fact that exemptions applied, and the inspector in question never verified that the exemptions applied, and it was rescinded by agreement. And so this is a non-valid document as far as I'm concerned, and I object to it on that basis.
If I may respond to that, I would say that's certainly something that counsel is entitled to argue in his closing, but this document was generated on the day that she went into the facility. It captures her impressions on that day and records them in her own handwriting. I think it assists the court in knowing what occurred on that day as part of just our facts about what she observed and that a violation was occurring at that time. Whether or not they ultimately reached some other outcome between the health department and Mr. Cooperrider in court doesn't in any way undermine the observations that are recorded in this document.
So I would say this in response. There was a dispute about exemptions that applied. And maybe I need to deal with it on cross, and I suppose I can, but and we've already kind of dealt with it in cross there was a state court action that ended up being dismissed as well. But I think it's irrelevant unless, it certainly doesn't establish a violation in my view, but I suppose I could also deal with it on cross.
I'm going to overrule the objection and let it be entered as just the record that was used that day. I understand there's many distinctions, and it sounds like the argument is going to come forth either through cross of this witness and possibly other evidence. So, but I've noted the basis of your objection, Mr. Wiest. Thank you. You can Ms. Foster.
What is the exhibit number that's been assigned to this, so I make sure I keep them straight?
For now, I'm just going to go ahead with 3, like the third that's been mentioned. And so if it has to be renumbered, we can work with that later, but we'll call exhibit 3.
Okay. Now, Ms. Sanders, when you provided Mr. Cooperrider with this notice to correct, at that time, were you going to shut down his indoor dining?
I was, with this particular piece of paperwork, that did not, that had nothing to do with the indoor dining. That's a different piece of paper. That would be a different document.
I'm gonna show you another document. And I guess before I get to that, so after you showed him or provided him with a notice of correct, what was his response to you about closing to indoor dining?
He said that he, when we went behind the counter and we were speaking, he said that he was calling his lawyer, and that he was going to be in contact with them concerning it. That the police department had already stated that they weren't going to support us. So he wanted to know what was going to be done. I just let him know that I needed to give him the two documents, the notice to correct and the notice of enforcement, and that this was an opportunity for him to stay open if he stopped the indoor dining.
And what was his response to that?
That he would speak to, that he was refusing to sign all of the documentation that I had. I let him know that I would call and speak to my supervisor to find out what next steps they would like me to take if he was not going to stop the indoor, not close, but to stop the indoor dining.
Okay, and what happened next?
I went out to my vehicle, spoke to Luke and Skip, let them know what was happening. While I was in there with Mr. Cooperrider in the restaurant, I was on the phone with Skip, and Skip let me know that he could refuse to sign, and that he was on his way, and that if Mr. Cooperrider's lawyer wanted to speak to Skip when he got there, that would be perfectly fine. So I went out to my car to wait for Skip to arrive.
Okay. Did you fill out any paperwork in your car?
Just the first 2 pages. When I first went in to do to start what would have been just a regular routine inspection, I noticed those things that were occurring, and Mr. Cooperrider let me know that he wasn't, he didn't want to stop the in-person dining. So I went out to my car to fill out the paperwork, and then I came back in, attempted to serve him the paperwork, and then I went back out to my vehicle to wait for Skip.
Let's see. I have another document that I want to show you. Can everyone see this document?
Yes.
Okay. Ms. Sanders, do you recognize this document?
Yes.
Is this your handwriting?
Yes, it is.
Can you explain to us what this document is?
It's a notice of enforcement. And we use that for if we need to ask someone to cease doing something, suspend their permit, revoke their permit. That's the main thing we use it for.
So would you say this is the next step after someone's received a notice to correct?
It can be. It just depends on what we're dealing with. With that, the next step for them, that was just my observations of them not having, or them still having in-person dining and not closed to in-person dining.
Okay, and I move to introduce this exhibit as well.
Mr. Wiest?
No objection on this one.
All right. It will be entered. This one will be number 4, tentatively. So, thank you. You may proceed, Ms. Foster.
And when you provided this document to Mr. Cooperrider, what was his response?
That he was not going to stop, that he felt that his garage door would account for the 50% and meet the guidelines.
Did you observe his garage door at that time?
I do not remember seeing it open, but I do remember seeing the garage door, and it did not equate to 50% or more of the outside of his facility.
Ms. Sanders, do you recognize the building in this photograph?
Yes, it's the Brood coffee shop.
Is this reasonably similar to how it appeared on the day of your visit in November last year?
Yes.
And I'm going to use my cursor since we're kind of limited here. But is this the garage door?
Yes.
Okay. At the time, with the Healthy at Work standards, would having that garage door open all the way have allowed Mr. Cooperrider to remain providing in-person dining at his facility?
Not on the inside, no.
Okay. Your Honor, I move to introduce this as Exhibit 5.
Therese?
I didn't hear her say, when was the photo taken?
Well, she didn't take the photo. But she verified that that is the establishment. This was provided with our compliance, and there was no objection.
I don't know that the foundation's been laid for this exhibit.
I'll take that under submission. I mean, she has provided plenty of testimony just based on her recollection of the events. And this was, helped her discuss it, but I will take that under submission. So if it's entered, then it will be number 5. But other than that, I guess we can move forward. Thank you.
Okay, Ms. Sanders, just to roll back a moment. So you had gone to your car and filled out the notice of enforcement, and you had called your supervisor. What happened next?
I waited for Skip to arrive. Because at that point there was no further action that I could take. So I waited for Skip to arrive, and when he arrived, I showed him the paperwork that I had filled out with the refuse to sign documented, and let him know what had occurred. Let him know that there were people filming us while we were in there, and we entered the establishment so that he could speak with the employees and with Mr. Cooperrider.
Okay, tell me more about that. When you had gone in previously with the notice, what occurred inside the premises as it relates to customers and employees?
When I first entered, as soon as I started speaking with Mr. Cooperrider, a few gentlemen came up and started asking me who I was, what I was doing there, why I was there. I let them know that I was with the health department. I gave them my name, let them know I was there to do a routine inspection. They started filming while I was talking to Mr. Cooperrider, getting closer than I'm used to customers getting while I'm doing an inspection. Then I left the facility to fill out the paperwork. When I came back in, Mr. Cooperrider was making some coffees. There was a woman standing at the counter. People were still sitting at their tables. When I was waiting for Mr. Cooperrider to finish making his coffee, the gentleman behind me started talking and filming, and the lady in front of me at the counter started filming. They were both talking at me. And while I was waiting for Mr. Cooperrider to finish making his coffees, I didn't feel comfortable with having people behind me, so I walked around so that I was able to see Mr. Cooperrider and the customers.
Is that something that normally happens when you go in to do an inspection of a location?
No, most people don't notice us.
How did that make you feel?
Very uncomfortable. Most interaction I have when I'm at a facility is with the permit holder and their employees. Most of the time, the only thing I've been asked is how to properly thaw something by a customer. Definitely not questioned as to what I'm doing there.
So what happened after Mr. Castleman arrived?
We went in, Skip reviewed the paperwork that I had given them. Mr. Cooperrider, I can't remember if it was Mr. Cooperrider or the female that was working there, let us know that they weren't going to be closing down for the in-person dining, and that asked what would happen if they refused to close. I believe Skip told them that they would have to ask for a hearing. If they still refused to close, that they could request a hearing, but that the next step, if they still refuse to close, would be a closure, a suspension of their permit.
And did they agree to close?
No.
What happened after that?
So we went out to our cars so that Skip could discuss things with Luke.
And who is Luke?
Luke is our supervisor, both mine and Skip's supervisor. And during that time, a gentleman was filming us, throwing questions at us about what kind of patriots we were and military service and things like that, filming our personal vehicles while we were standing next to them.
I'm going to object to the hearsay. This isn't a witness, but this isn't a person by the company that was making these statements. It was a third party, and I don't think it has anything to do with this case.
I mean, she's testifying as to her own observations.
Sure,
and it does have to do with the case, because the case is about a disorderly premises and the failure to follow the rules, and certainly allowing customers to intimidate people that are just doing their jobs and giving notices does play into that. And we can make arguments on that later.
So her testimony was this was the parking lot. This was not within the premises itself, and I think it's irrelevant. It's a 403 issue. It's not admissible. It's hearsay. I mean, there's all kinds of problems.
I'm going to allow the testimony as, under 13B, hearsay is admissible. The difference, distinction being that when a finding is being made, it cannot be made solely on hearsay that's been admitted into the record. So the testimony is allowable under the KRS 13B statute. So I'll let the questions continue. Ms. Foster.
Okay, so after you guys have filled out the paperwork in the parking lot, what happened next?
We went back in so that he could serve the second enforcement notice. I did not do, from the point Skip arrived to the time we left, I did not fill out or hand out any other paperwork. At that point, it was Skip that took over the enforcement actions.
And did you guys, in fact, close the business on this date?
Yes, there was a closed, I believe it was a final notice of enforcement. Again, I didn't fill out that paperwork, so I can't speak. I can't remember exactly what order that was, but Skip did post a closure sign and let them know that they were closed.
And what happened when you left the premises?
Mr. Cooperrider and his employees followed us out. I mean, not the employees, I'm sorry, let me rephrase that. Mr. Cooperrider and the customers followed us out to our vehicles, throwing questions at us and things. They followed us. Skip, as we were walking out, Skip told me just to get in my car and go. When I went to get in my vehicle, I wasn't able to back out because there was a gentleman filming the interaction that was blocking my ability to back up. When I got out of the vehicle to ask him to move so that I could leave, that's when I started hearing Mr. Cooperrider yelling at Skip and started cussing at him, and everyone was just yelling and getting very loud. And as soon as the gentleman moved, I got back in my car. I backed out of the parking lot and left. And I called Luke to let him know what was happening and to ask what if I should, because I was concerned that it might possibly get violent. So I needed to know if I had, if I should call 911 witnessed any of that.
While this order of closure to indoor dining was in effect, did you have any other inspections that occurred where businesses were open to indoor dining?
I only had one.
And what happened briefly when you spoke to that owner?
I let him know that his garage door that he had opened did not meet the 50% rule.
I'm sorry. I think maybe you misunderstood my question.
Oh, I'm sorry.
I was asking if there were any other businesses that you encountered during the closure of indoor dining that were remaining open.
Yes, and they actually had a garage door as well. Sorry.
Okay.
I'm sorry. They had a garage door as well that was open that they thought met the requirements. I let them know that wasn't possible. They immediately told their servers to not seat anyone and switched back to carry out and take out only.
Okay. Now, I know that you guys had issued these notices of enforcement, or you've testified that those were issued. Did this case end up going to court?
It did, yes.
Did you have to testify in that matter?
Yes, I did.
Are you aware of whether or not the court issued a ruling that Mr. Cooperrider needed to close his business?
I understand that there were rulings. As to what those were, to be perfectly honest, as soon as that day was over, I tried to step back after the testimony because at that point it was above my pay grade for how things were being handled.
Okay. All right. I have no further questions for this witness at this time.
Great. Mr. Wiest?
Good afternoon, Ms. Sanders. Let me ask, I'm going to start with the mask mandate. You said that the mask violation that you wrote, you thought was a violation of Executive Order 2025-86, fair?
I'm sorry, my screen just went blank. I'm sorry, 2 seconds. I'm not sure what just happened. Okay, sorry about that.
You said that it was your recollection that the mask violation that you wrote for Brood was a violation of 2025-86, correct?
That's the executive order and the Kentucky Healthy at Work. That is what I was instructed to put on any mask mandate.
And you testified about that in circuit court in Fayette County as well, correct?
Yes.
And do you remember me asking you in that case whether or not you determined whether or not any exemptions applied to the customers that you saw without masks?
Yes, I did.
You said you did not determine whether or not an exemption applied, correct?
No, I did not, sir.
And the same is true for anyone that you saw not wearing a mask. You're not sure whether or not an exemption applied, correct?
The only thing that I was told by Mr. Cooperrider was that he had asked his employees or his customers to wear masks in the past, and they said that they weren't going to, and he couldn't make them. That is the only thing that I know in terms of his customers not wearing masks.
But in terms of what you observed that day, you don't know whether or not those folks that you saw without masks were the subject of a valid exemption, correct?
No.
That is correct, right? You don't know.
Yes, that's correct. I'm sorry.
And there were exemptions, I believe, for people who have disabilities or physical or mental impairment that prevents them from safely wearing a face covering, correct?
Again, I don't have a copy of the.
Let's look at it. Yeah, that's fine. I'm going to put it up in front of you. It'll be helpful for probably everyone. So let's look at just for purposes of there's the executive order, right? It's been in effect since July of 2020.
Okay.
Again, the following are exempt from wearing a face covering, and there is what I just read to you: a person with disability or physical or mental impairment that prevents them from safely wearing a face covering. Correct?
Yes.
So we don't know, as we sit here today, whether or not there was, in fact, a mask violation without knowing whether or not the people were the subject of an exemption. Fair?
Correct.
Okay. I want to get back to the food shutdown issue. And do you recall Mr. Cooperrider indicating that he was operating under the event space requirements?
That was never mentioned to me at any time that day, sir.
Okay. You know whether or not he ever took that position?
Not to me. I never heard that. That was never mentioned to me on that day. No.
Let's just take a quick look at, I think it was Executive Order 2020-968, correct? Right? Wasn't that the executive order that shut down indoor dining?
I don't have the number in front of me, so I'm sorry.
We can go look at it. I don't think I'm going to introduce it, but I want to, if I can find it. To be clear, this was the Governor's Executive Order, November 18th, 2020. Do you see that?
Yes.
And it did shut down indoor dining for restaurants and bars, correct?
Yes.
But it also allowed venues and event spaces to continue to operate as long as they had 25 people or less. Fair?
Yes.
Okay. Did you witness more than 25 people in the room on the date in question?
I don't remember counting the number because what I had in front of me that he was operating as a restaurant, and any in-person dining at that point wouldn't have been allowed. Even though the order itself indicated that indoor venues, if it was an event space, could have 25 people per room? I was never told by anyone, including Mr. Cooperrider, that he was an event space. Okay. All right. Let me ask, when you first came in, did you tell Mr. Cooperrider that you were uncomfortable? Not at that time, but when we stepped behind to speak with him, when I was having him sign the paperwork, I let him know that I was uncomfortable, yes. And when you did that, he brought you into the kitchen so you weren't exposed to anyone in the No, that was mentioned after I asked him if we could go back behind. I asked if we could go back behind, and then I let him know that the filming was making me uncomfortable. In response to that, he allowed you to go back into the kitchen with him to have the discussion, correct? When I asked him if we could go back behind, yes, but at that point I had not mentioned that I was uncomfortable, no. The people in there were two groups in there that day, correct? I don't know how many groups were in there, sir. I'm sorry. You know whether or not the people in there were appropriately engaged in appropriate 6-foot physical distancing? There were times when people I felt were closer to me than 6 feet. As concerning who was grouped with who, that I couldn't tell you. Did you measure it? No, sir. Okay. Do you know whether or not anyone within the restaurant that day had a COVID diagnosis? No, sir. And as I understand it, let me ask, did anyone yell at you within the restaurant premises itself? Yes. When Skip was issuing the final enforcement notice and the letting him know that we'd be putting up the closure sign, people started yelling. Somebody was yelling out, make sure you ask for a hearing, and some other things. So yes, there were customers yelling at us. They were yelling about the contents of it and what Mr. Cooperrider should do in response? Yes. Okay. Did any of them threaten you personally? No, there was no threat of violence spoken, no. How many square feet is the facility? I don't know, sir. Do you know what HVAC equipment or systems they had in place? No, sir. When you first came in, was the garage door open? I do not recall seeing it open. It wasn't open significantly enough for me to realize that it was an open garage door. It was not fully open. I think I asked you, so I just want to be clear. You don't know what the HVAC systems that they had in place that day were, fair? Yeah, no, I do not know that. To be a threat to be a threat in terms of COVID spreading, somebody would have to have COVID within the facility itself, wouldn't they? To catch a disease, you would have to be around someone that had the disease, correct? I think your testimony was we don't know whether anyone there that day actually had a diagnosis, correct? No, sir. Was anyone there serving or drinking alcohol that day? I do not know. I only saw Mr. Cooperrider preparing coffees.
Okay. I think you testified Mr. Cooperrider raised his voice at one point in time and may have used a profane word. Was that outside?
Yes, it was.
It was in the parking lot, not within the confines of the four walls of the facility.
Correct. It was next to Skip Castleman's vehicle.
Did he threaten Skip in any way? Did he threaten him with violence?
To be honest, sir, as soon as I heard the screaming and the cussing, and I got in my vehicle and exited as quickly as possible because I did not feel safe.
Did anyone brandish a weapon?
I do not remember seeing a weapon, no.
Would that be something that if someone did, you would have remembered probably?
If I saw a weapon, I'm sure I would have remembered it. Yes, I do not remember a weapon.
Did Mr. Cooperrider make any gestures of violence towards Skip in any way that you saw?
He was throwing his arms around while he was talking.
Because he was upset?
I can't speak to his state of mind, sir.
Okay. If he's raising his arms and was he saying that he wanted a hearing?
At one point while we were inside, I do recall him asking for a hearing as we were walking out, yes.
Did he indicate that Skip, was his frustration that this closure could result in the shutdown of his business?
He repeated that multiple times because he said he wasn't Starbucks.
And so he basically indicated he could not stay open because of this order? Was that why he was screaming?
He indicated that was his feeling, that if he closed to indoor dining, that he could not provide enough business, yes.
And that was primarily what he was screaming?
Like I said, I don't remember
objection.
all of it.
This is asked and answered. He's asked her several times what he said, and she's repeated herself numerous times.
Any response, Mr. Wiest?
Yeah, I'm trying to get to the answer here, and I don't know that it really has been answered. I'm trying to get into the specifics of this. Obviously, the claim by the other side is that, that this all gives rise to a disorderly premises and whatnot. And I think getting the context of what exactly was being screamed, if you will, is important. Context always matters. So I think getting to the heart of this is critical, and I don't know that it's been fleshed out yet.
I will overrule because I do think that there's been enough variation to say that it's not the same exact question, and it does seem like each answer provides a little bit more information or different information. So I'll let Mr. Wiest continue, but I think you see that it needs to move forward too.
Ma'am, other than concern about being able to remain open, and I think you said he indicated he used a one-time used a profane word. Did he scream anything else out that sticks in your mind as we sit here today in terms of the content of the speech?
No, sir. As soon as I got out of my car, started hearing the yelling, and the gentleman finally moved after I asked him to because he was filming. I got back in my vehicle and I exited as quickly as possible.
And you don't know what, if anything, Mr. Cooperrider did in response to the individual in question, correct? Following that?
I'm sorry. Are you meaning what he did to Skip?
No, I mean after the guy that was blocking. Do you know whether or not he asked the guy to move?
I asked the gentleman to move, and he moved.
You know if Mr. Cooperrider, after all that, asked the gentleman to leave or not?
I pulled away and drove away, and I pulled off. I didn't make it to the main road, but I pulled away far enough that I could call Luke to see if I needed to call 911 in case things got violent. As soon as Skip got in his car and was able to exit the parking lot, I drove the rest of the way away from the building.
Okay. I do not believe I have anything further.
Okay, Ms. Foster, do you have any redirect?
I do. I have some brief redirect. You were just asked, Ms. Sanders, whether or not you were aware if customers inside the building had exemptions not to wear masks.
Correct.
Whose responsibility is it to determine whether or not somebody has an exemption?
According to the way that I was taught and trained, that would be up to the permit holder because they are the ones that are legally responsible for their facilities.
And on this date, wasn't the business supposed to be closed to indoor dining?
Yes.
So it really wouldn't matter if people had an excuse not to be wearing a mask because they weren't supposed to be inside the facility on that day. Is that correct?
In terms of the indoor dining, no one should have been there.
When you arrived, you said you were there to complete an inspection. Were you able to do the inspection?
No. As soon as the closure notice was issued, as soon as there was evidence that there was going to be no closure for in-person dining, and once we had to issue the closure notice, there was no reason to inspect that day.
Did you notice whether or not the restaurant was serving drinks and food to customers?
I know that coffee was served, yes.
Okay. And during these events that we've heard testimony about with the customers interfering and yelling, did the owner, Mr. Cooperrider, or any other employees try to calm the customers or ask them to step away so that he could speak with you and conduct business?
Not that I remember.
All right, thank you. I have no further questions for this witness.
Mr. Wiest, any recross?
Yeah, just a brief question. Ma'am, this event was about 7 months ago, fair?
Yes.
Okay. Do you remember every detail of every interaction you had from 7 months ago?
No, sir, but when I feel nervous or threatened, I tend to remember things a little more clearly.
Do you think as you sit here today that you remembered every single detail of that interaction?
Unfortunately, I do not have that kind of memory, no.
Thank you. Nothing further.
All right. Ms. Foster, do you plan on recalling Ms. Sanders, or is she excused as far as ABC is concerned?
I think this witness may be excused.
All right. Thank you so much, Ms. Sanders, for being here today. I appreciate your presence and cooperation. Thank you.
Thank you.
All right. You're excused. We're at 11:52. And I think this would be a good time to break for lunch, and then we can bring the next witness, either Mr. Castleman or Ms. Estes. Are you aware, Ms. Foster, which party is going to be called next?
Yes, Mr. Castleman will be called next, and I anticipate his testimony is going to take, as long as Ms. Sanders did.
All right, guys, that's the end of part 1 of our court hearing here. Hopefully you guys were able to hear how much the state's amazing, fantastic, insanely smart COVID expert was. And you can start to ask yourself the questions we've been asking as we dive deep into not just our court hearings, but others, as we listen to them and listen to these experts and start to wonder who is actually driving the ship, because they don't seem to know a thing about what they're doing. Like I said, part 2 is coming up, guys, in the next episode there. I thank you guys for listening and listening to the next one. Please support us. You can go to shop.broodco.com. That's shop.brewedco.com. You can also give us money if you just want to give us money at donate.broodco.com. And please tell your friends, tell your family about us, and let's get this story told.